I think the cases shared by Sachin and maybe Venki also would be something like in some ads, heroes perform a big, fantastic tasks, and there will be a warning not to be attempted by individuals at home.
Yes. Thank you, sir. Thank you for this opportunity. And I think it is a perfect opportunity for me to present this case after Venki's case because it had completely different spectrum of intervention. And this case is completely different. Aim of both the procedures was salvaging AV fistula. So, uh, So this is a 50-year female. Is on maintenance dialysis some elsewhere. Her left wrist AV fistula was constructed by myself about an year back. She came to us with history of poor flow during dialysis. And this was the picture. Clinically, also we can see there is a blackling. There is a skin overlying the venous segment of the AV fistula. This is the left wrist AV fistula, radiocephalic. It was like that area was hard on palpation. On Doppler, there was complete thrombosis, and this segment is about 6 to 7 centimeter. Uh, then I think we took it. No, I think I posted a wrong video, but this is after the surgery. Before surgery, when we did a shoot for this patient, there was no forward flow at all, and the entire flow was retrograde into radial artery. It showed that the anastomosis was patent. I think one important thing I want to point out here is the anastomosis was patent. There was no perianastomotic stenosis, no problem in AV fistula, but this segment was about 3 to 4 centimeter after beyond anastomosis, and this was completely thrombosed. So at this point of time, as Venki pointed out, the multiple options which we have is somebody like Venki would consider percutaneous intervention and do a venoplasty uh, in a uh, in a resourceful setting. But we have seen that all these lesions who undergo, like this was a very tight lesion. I believe that it was difficult for percutaneous intervention as well. And even if it is done successfully, there is always a risk of restenosis. We can consider surgical thrombectomy and repair, but again, I believe there will be a risk of restenosis. Proximalization is one option. People like Shabaz or Girish would prefer this proximalization where you can go a step up, cut the vein proximal to the thrombosis and anastomose with the radial artery. But this segment being long, I think proximalization would mean that you are digging out radial artery which is deeply situated at that point of time, or creating a new fistula means, but that would amount to giving up your existing access. So these are like some negatives of each procedure which I already mentioned. uh, in this patient, we had some additional observation. Because of thrombosed segment, there was one collateral. Again, remember that AV fistula is patent and it is giving radiocephalic fistula. Cephalic fistula segment is thrombosed, and there was a collateral. Because of this extensive thrombosis, this collateral got arterialized, and this was coursing towards dorsum of hand, which is leading to venous hypertension of left hand. So I hope the image is clear. So there is a thrombosed segment. That top arrow is pointing to a thrombosed segment, and this is the arterialized collateral, the lower one, if it is visible in this image. So this was something which we observed. Now, then when I pronated the hand further, so along with this arterialized collateral, naturally there were some other prominent veins on dorsum of hand, which again could be effect of a higher flow to the hand. These are normal veins which are otherwise also present, but they became more prominent because of this arterialized collateral getting the flow to that area. So this small vein, small prominent vein on the dorsum of fan, I got this vein mapped with the help of Doppler, and it was observed that this particular small vein is draining into cephalic vein at elbow level, and there was no thrombosis in the course. So that thrombosed segment of cephalic vein was getting bypassed by this vein. So what I did was I took a horizontal incision on dorsum of the palm, mobilized this arterialized collateral, and also mobilized this prominent vein, and did this small vein was tied and cut, and then I passed infant feeding tube in that particular vein to just to confirm. Like on Doppler, it was patent, but this being a small vein, I just wanted to check its caliber. So 5 number infant feeding tube was passed. Vein was found to be patent, and I tried to palpate the location of the infant feeding tube. It got palpated in the elbow level. So on Doppler also, we documented that this small vein is draining to cephalic vein, and even this feeding tube was getting palpated at the elbow level, indirectly suggesting that this vein is really draining into the elbow veins. So next was we performed end to side anastomosis. That was a venovenous anastomosis. So the prominent small vein was anastomosed to the arterialized collateral, and this is the observation. So on the top is the small vein, and this incision is on the dorsum of hand. On the top, what we are seeing is the end of the small vein, and the C which we are seeing is the arterialized venous collateral. So end of that small vein to arterialized collateral anastomosis we did, and I hope that sound gets transmitted. On the table itself, we tried to check the flow in this small arterialized collateral. I hope the sound is audible, and there was a clear-cut audible buoy in that vein and the entire course. We mapped this to, to the elbow level, and you can see a very clear buoy.
Yes.
So this was, and just immediately at the end of the procedure, I hope this image is clearly visible. We could see all prominent veins, suggesting a successful anastomosis and fistula. After 4 weeks, we reassessed this patient. So venovenous anastomosis was normal. Vein diameter at in the cephalic vein was more than 6 mm. Flow was more than 300. All maturity parameters were satisfied. This is the Doppler image. This is the diameter of the vein proximal to, like, upstream the venovenous anastomosis at elbow level. And subsequently, the patient underwent successful dialysis, and we could achieve flow of 300 with this particular fistula. So So basically, it was a venovenous bypass to salvage this particular AV fistula, and this can be, like, along with all the options which we discussed, like proximalization or surgical thrombectomy or interventional IR procedure. This can be an additional option. Of course, I was lucky to have this kind of anatomy in the patient where AV fistula anastomosis was patent. I had a collateral which had a very good flow. It was arterialized flow, and there was adjacent vein, and there was no upstream thrombosis. There was isolated thrombosis of that particular segment, which I could bypass by this particular procedure. It was a situational decision. This also helped to mitigate venous hypertension of the hand in this particular patient. I tried to do a literature search. Such kind of approach is unreported in literature, but now there are a lot of my teachers and senior doctors here. They may have, if they have come across, they can comment upon this. And it just tells us that unconventional approaches can also help the patient. Like we can use horses for the courses, and it was a, as I said, it was a situational decision which right now seems to have worked for this particular patient. I think that's all I had to share.
Thank you, Sachin. And surgically oriented interventionalist. Uh, any
Just I wanted to speak about the fistula sir was talking about Rajapurkar sir. So that fistula, lower limb fistula is anastomosis, like first anastomosis at the femoral vein to femoral artery. Then you take second incision at thigh level, lower thigh level. There you reach up to popliteal artery. There is a femoral-popliteal vein. So you identify that femoral popliteal vein, you resect it, put it in subcutaneous tunnel and create. So there are two arteries you are taking. One artery at groin level is a femoral artery. Second artery at the thigh level is a popliteal artery. And you use that femoral vein or saphenous vein for superficialize. Like so you put that into subcutaneous tunnel and create anastosis, and that's how lower limb fistula is created.
Thank you. And there is a suggestion by Dr. Preet. After anastomosis, you could have ligated distal to avoid any reflux. Does he?
That arterialized collateral he meant,
I
which was
think
going
so.
to a
Yes,
dorsum of hand.
yes.
Yeah,
That looks like Sachin. Yes.
no, but as the flow, because of that vein, natural flow is upwards. So after that anastomosis, the flow got diverted to elbow region. On table also, I saw that all the prominent veins, which were like, we all know that when patient develops venous hypertension, patient gets a pulsating pain as well as there will be a swelling. But as soon as I finished that anastomosis, that swelling appeared to have gone down, and that pain, the pulsating pain which the patient was feeling, that also disappeared. So that was one of the reasons I didn't think about kind of putting a ligature, which is of course a good suggestion, and it was very simple thing on that table. But because patient had mitigation of those symptoms, I didn't think appropriate to do it at that point of time.
Yes, Dr. Anil has raised his hand. Sir,
All right, so I have a brief comment. First of all, thank you, Dr. Soni. Great case and great innovation. It's always the imagination of the interventionalist how they can utilize a vein that might be available. So whenever there is a upstream stenosis, most of the times, if you're lucky, there'll be a good collateral vein. And these collateral veins, eventually their purpose is to drain into the central venous system. So every time I see a significant collateral vein, I do an angiogram to see where exactly it is going. If it is already going into the central venous system without anything, you could potentially utilize that to do the dialysis. You don't really have to make any connection, any surgery. I have previously utilized where there was a retrograde flow. So you put one arterial needle to draw blood from that, and then upstream, directed upwards needle to return the blood. So I have dialyzed people like that, and they did just fine. Yeah, you don't have to make any connection. So it's a good idea to do an angiogram of that vein to see where exactly it goes. If it is stenosis free, it's a decent size. If there is a minor stricture or something, you could do actually an angioplasty to make it a little bit bigger. So it serves as a brand new fistula for you. So I think that is something that can be done. And the other thing you sort of did that. So you took the vein from the hand, and you connected it back to the fistula above the thrombosis, right?
So it was,
that's the
it was anastomosis from vein to vein only, sir.
Vein to vein
Yeah,
to vein. Yeah.
vein to vein. So there was like
Yes.
normally we many times people tend to even ligate that vein at the time of creation of AV fistula. Maybe I didn't do it and it was slightly far off, but that particular vein which was going downwards towards the dorsum of hand,
Right.
that had a good flow, and with that only, like that entire anastomosis was done at the dorsum of hand. So I didn't
Yeah.
come towards AV fistula at all. And the point which you made, like I would like to just propose how this case was different, because that small vein which I mentioned was really small and it couldn't accommodate a needle without anastomosis. And if I had continued to utilize the collateral which is going towards hand, then the patient already had issues of venous hypertension. So this procedure not only helped for say arterialization of rest of the venous capital of the hand, also reestablished the flow in the elbow veins like cephalic vein as well as medial cubital vein. At the same time, it helped to mitigate the venous hypertension of the hand.
Sure. So you have to make sure that this flow is not going into the hand, otherwise you will have that venous hypertension.
Yeah.
So it is all in the mindset. There is no artery or vein. When that vein is getting all the flow from the artery, it's an arterialized vein. So it is essentially equivalent of the artery, and that's what you utilize. So people have to think about utilizing the arterialized part of the vein as an artery potentially to make anastomosis with that. So we have done that and utilized those things. We didn't publish or anything, but then I may have published something about utilizing a retrograde vein to dialyze, but it's very plausible that you could utilize those segments of vein. The collateral veins are not your enemies, though those can be friends. You don't have to sacrifice them, ligate them every single time, and sometimes those are the lifesavers. So that's a good thing that you did. The other thing you potentially could have done it as a simple procedure would be to connect the artery with the vein above the stenosis with a graft. I mean, that would have been another simpler measure. So as long as you are patient-centered, utilizing existing possibilities, I think it's not too much at that point. But then at the same time, think about how you could do the minimum intervention. And minimum intervention is always the best for the patient. It's most economical. It will save vein and the fistula for later on because most of these people are younger. In India, the irony is that most, as opposed to US, where the geriatric population is going on dialysis, it's happening in US also, but there are a lot of young people in India who are undergoing dialysis and they need their access for a long period of time. But thank you. Great job and very well done. Thank you.
Thank you.
Talking about the retrograde flowing vein in a brachiocephalic fistula, now and then I see this retrograde flowing vein, and I have utilized it for putting in the sheath for angioplasty and reaching the brachial veins. You catch the point? Like instead of
Yes.
puncturing the real cephalic vein, you enter through this retrograde flowing vein, which is often in the forearm cephalic side. Any
Sachin,
other?
what is Sachin?
Yeah,
How
tell
would
me.
you compare it to anastomosing this smaller vein to the radial artery itself? Do you think that is technically possible, like a new anastomosis?
Come again, Venki. You wanted to know about
Yeah. How
difficulty in
about
anastomosis?
anastomosing this? No. How about anastomosing this smaller vein to
Uh,
the radial artery itself, as like creating a new radiocephalic fistula?
so now that vein is far away from the radial artery, Venki.
Okay.
And as sir has mentioned, this arterialized vein served as an extension of radial artery, which was very
Okay.
close to that particular vein. I don't know
Yeah.
if I am able to
Yes.
give a visual impression what was the situation,
Yeah.
but
It was
yeah,
very
yeah.
clear.
So this vein this vein was practically a radial artery, as sir suggested. It was extension of radial artery, and it was in close proximity of that vein. So I said, as I said, it was a situational decision, looking at the anatomy, and to my luck or patient's luck, that particular vein, that small vein which I chose for anastomosis, was draining above that thrombosed segment. So it bypassed that thrombosed segment. So I did nothing to
Yeah.
that thrombosed segment. It is still in the patient's hand, but that fistula is functional. That's how it has happened.
Yeah.
So it will be a very difficult task to move that vein to radial artery. It will create kink, and I think it will be a tough, difficult anastomosis, so to say. It will involve a lot of dissection. This was a very small incision. You could have seen, like I
Yes.
think it was just 6, maybe about 1.5 centimeter incision. Both the veins were in close proximity, and anastomosis was also not difficult because the receiver vein, as I said, was like artery. It was a big one, and it was an easy end to side anastomosis. So technically, like with respect to skill level, like you did exceptionally skilled job in doing plasties for all those patients. So skill wise, this wasn't difficult. It was easy job. But I think the thought was useful for the patient. Thought was the innovation, not the skill.
Thank you, sir.
Sachin, I thought what you did was absolutely fantastic. This is Adrian. We always say we can put a patch graft, but the problem down the line is there will be a stenosis coming where the graft meets that vein, and you'll be going in and fixing. But you created a fistula, absolutely amazing. That's all I have to say. I can't add anything else. I think Dr. Agarwal said a bunch of what everybody's comments are. He put everything well together, but that was fantastic. I'm going to look for that now so I can tell my surgeon also, hey, why don't we try something like this? And I'll look smart. But good
You try
job.
to write this, sir. We keep
You
doing
should.
things and don't write. So I'll try to
Well, you
write
can
this, sir.
present it as an abstracted avatar. I'm sure one of us somebody will see it and learn something from it.
Yes, yes.
And coming, I just listening to all this that you said, I want to come back to Venki and his case. Venki, in that lady that you put a left brachiocephalic, why couldn't you do a left radiocephalic? Was there a reason?
No, it was not there, sir. That is the only vein
It was
available
not
on
there.
the.
Okay,
Yes, yes.
got it. Okay,
The
that's
right
all I
vein is
wanted.
there. Yes, sir.
Good job.
Right. Uh, Anybody else want to share anything? Is there anything in the chat box? Just a minute.
I just want to raise one small point, sir. Agrawal
Yes.
sir mentioned about heating catheters, but it is my increasing observation that my all new colleagues, they just prefer putting cuff catheters, and quite frequently even option of AV fistula is not explained till the time that cuff catheter gets into problem. So I don't know if there is any change in teaching now, or that is a preference, cuff catheter is a preference of time. So any opinion on that?
Yeah, everybody is busy. I think it's the easiest thing. The patient comes and put in a catheter. Well, what beats me, and sometimes it is because the patient also, they don't want an AV fistula started before they actually get on dialysis and all that. What beats me is that after you put one catheter, why do you have to wait for it to go away, develop a stenosis, then you put a second one on the other side, then get that stenosis, and then think about fistula. I think having a catheter for a week should be enough of the torture to, start thinking about putting in an AV fistula and potentially avoiding a longer term catheter with infection, central stenosis, and all those kind of things. So I don't think there is any difference in teaching. I think it's the practice pattern, what is easy. We have a huge country of India, very few nephrologists, and even lesser number of interventional nephrologists. I mean, who has time, all the time to teach those patients? So I think that's where the education comes in play. We need to teach our, fellows from the very beginning that go for an AV fistula. Yes, you can start with the catheters. Okay, if you have to. But then try starting with the fistula. In India, people are so skilled, all you nephrologists. I'm envious of you. I mean, you can create AV fistula. I've never created an AV fistula myself. So we depend on surgeons. You guys are smart. I mean, it is just ironic that in India we will have problem with the catheters. Honestly, it's cheaper, better. You guys can do yourself. You're not dependent on anybody. Go for it.
The other thing also I would add there is also when the patient is losing his transplant kidney. Very often I see the transplant nephrologist will also put the catheter. He's not even thinking ahead about a new access. So I'm wondering if that is the same situation in India as well, because I would think the persons who are putting the kidney are also can put the accesses as well. Yet in the United States, the transplant nephrologists hold on to this kidney till the GFR is 5, 4, and then he will say it's time for an access, and the access will be a tunnel dialysis catheter. So I don't know if this is the same thing that's going on in India as well.
Adrian, let you bring up such an important point. And I talk with my transplant nephrologist all the time. So in people who are pre-dialysis and have never had dialysis before, I understand it's difficult when it is starting. They don't have nephrology follow-up. We have complained about that they never come to nephrologist. We couldn't put fistula. Transplant nephrologist. This patient has been with them for 10 years. Kidney is failing. We know that for the last 6 months that they're going to need dialysis. Why do they start with a catheter and not with a fistula? I have argued with them. And they all, oh, well, So I think part of it is that they don't want to accept failure, that the transplant is failing, and we want to start. There is some resistance from the patient also, but be logistical. It's going to fail. Yeah, you better put in a fistula. You will be surprised to know. I actually looked at the database at Ohio State, and the transplant patients starting with catheter was exactly the same as people who had never had nephrology follow-up before and were starting with a catheter. So it's our failure too.
Thank you, Dr. Anil. And Dr. Venkatramanan, you've been waiting to give your thoughts. Yeah, come.
Sir, good evening, Pala, sir. And I think it's a wonderful presentation by Sachin. Sir, I am one question to the forum, sir. Actually, 2 weeks before I created one fistula, but it was totally calcified radial artery. I have tried to remove the calcification for anastomosis. That's almost like a eggshell brittle. Then the artery went through and through. But I thought that I will do instead of side-to-end anastomosis, end-to-end anastomosis. But I am not able to because I am not able to see the lumen of the artery. Then even I tried the brachial for the same patient, but still the brachial artery is also severely calcified, sir. So what is your advice for this type of patients and how to proceed?
Well, I think that kind of artery should have been detected before the surgery was planned. That is number one. A good Doppler would have told you that there is hardly any lumen. But calcified arteries is a common thing. And while the technique, when you do your arteriotomy, you do a slightly larger arteriotomy and don't try to remove the atheroma. On the arterial side, your stitches should always be from in to out rather than from out to in. When you do from out to in on the arterial side, you dissect the artery of the atheroma. Whereas when you go from in to out on the arterial side, on the venous side, it doesn't matter. So about a 2 millimeter longer than what you would have otherwise done. And then make sure that you don't use a very crushing bulldog clamp. Better to hold it yourself or somebody who's more used to doing that with you. So if the bulldog is crushing, again, that is the place where the atheroma gets separated.
Yeah. Plus, you take a tongue flap and you don't just make an incision through the atheroma. I mean the calcified atheroma. You dissect out a tongue flap. That way it remains patent. Otherwise, it will draw the vein together and
so it will thrombose.
your anastomosis might be good. There won't be blood flow. But I think Venkatraman is mentioning about a case where he did not see any flow at all. There, I think, as Professor said, Doppler, pre-procedure Doppler should have sort of showed this.
Yes, sir.
E-
Yes, sir.
Even
Previously, I created a lot of fistula in calcified, sir. Most of the time, they have systolic hypertension, and then most of the time after that, it's a good flows there. But this is the time I am trying to clear that calcification. It went for through and through of the radial artery. So then I thought that I created a side to side, end to side anastomosis. So this is any you are advised to side end to end anastomosis, sir. Whether it is advisable for the radial artery to end to side anastomosis if there is any through and through of radial artery.
Yes, yes, you can always do end-to-end anastomosis. There is no problem. And
Okay.
what sutures are you using, Venkatraman, for these calcified vessels?
Normally, I am using 70 double-headed rolling, sir.
So I think that if you are encountering calcified artery, like that is my approach. I don't know what science says. So I use 6O needle, 6O
Okay.
proline with 13 needle. So 13 black needle.
Black.
So
Okay, yeah.
yeah, that will help you to go through to take the sutures. And sir has already pointed out, Rajapurkar sir, don't make attempt to take out this calcified plaque. Then
Okay.
your arteriotomy will keep getting bigger and bigger, and then it also becomes irregular. So I think that was probably the problem which you faced when you did a radial anastomosis. I think elbow level there should not have been a problem because and generally calcified artery AV fistula they generally work. I compared
Yeah.
to I don't know what is the reason why they generally tend to work. They don't
Yeah,
fail or
that
get.
may
Yeah.
be isolated systolic hypertension. Most of all the
Yeah.
patients.
Yes,
That
yes,
may be.
because of vascular calcification.
Yeah.
So maybe consider using 6O proline next time with black needle 13
Okay.
Yeah.
Thanks.
Sachin, what I have seen that if your fistula, I mean, if you get a flow going on the table, even if the
Mm.
artery is heavily calcified,
Mm.
still it works. But the
Yeah, yeah.
size of the artery would be somewhere around at least 1 centimeter, 10 or 12 That is what I often use with the radial artery.
Yes, yes. Bigger venotomy you are talking about.
Arteriotomy. I mean, that has to
Arteriotomy,
be
yes.
a really big
So
one, not
ultimately, so when you are kind of trying to make it a good arteriotomy in calcified vessel, as I said, that arteriotomy keeps getting bigger. So yeah, what you say is right, and they generally work, but
yeah,
calcified,
I mean,
yeah, yeah,
they really work. Last time I got in big trouble that I was
yeah,
trying to make a snub box AF, and I'd never seen such a calcified that wherever I could increase the size, and ultimately I had to abandon it.
yeah, yeah.
May I ask you, Sachin, one thing? I mean, maybe not directly related to the presentation. So, how
Yes.
often would you like to ligate the dorsal cephalic vein? Because that is the one which becomes prominent if you have some proximal stenosis or thrombosis of the cephalic when you construct radiocephalic fistula. So that vein becomes prominent. Probably that's what you had used for constructing a new anastomosis.
Yes. So I think it will again depend what is your site of anastomosis. So if your that dorsal cephalic vein is accessible to you when you are creating fistula, I will just put a clip. I will put a Liga clip there. In this particular patient, probably that anastomosis was far away and I didn't have access to that vein to put a clip. So that's why it remained. But in a way, it was blessing in disguise. It helped the patient right now. Yeah.
Hi, Sachin. This is Himanshu. So I'm a
Yes.
vascular surgeon. So sorry,
Yeah,
my
you
name.
can give us better inputs about whatever we are talking about.
I've logged in through my wife's laptop, so it comes as a brief. So hi, Anil sir. So it was really nice, and I must first start with that I'm really your fan because of the first case which I have seen, being a nephrologist and digging out the brachial vein from deep is not easy. And I think this was 2 years back in Avatar.
Yes.
Here in this particular case, it was a very good approach. My take whenever I deal with any patients who have got a failed fistula, in angiogram, everything looks in black and white. Whenever we see a occluded segment, it simply reflects failure of the procedure. So we should always look in hindsight what was the reason that has caused it. Was it a swing point stenosis eventually turned into occlusion? Was it actually a puncture point stenosis? In cephalic arch, was it the cephalic arch occlusion or stenosis? Because that helps. If this patient had a difficult technician, probably you will need to train the technicians also in future. The reflux point is, I thought, whenever we do, say, just take it like if you have done a radiocephalic fistula, which is not maturing, when you do end to side, it's actually very good to do end to side that anastomosis you exactly did, because the size mismatch does not become an issue. But ligating distal vein, which is going towards the hand, kind of helps, because your vein, which is around 5 millimeter, will dilate better. Okay, it will, because it will have much more forward force making it dilate. So yeah, that was one of the things, some of the things. And your point regarding leg fistula, I actually recently did, I think maybe second one over last 10 years. And the problem with the great saphenous vein, Sachin, that it's a very muscular vein. It does not dilate. So if somebody really needs it, you have to dig down, and you can actually harvest the length of femoral vein for good 15 centimeters, 15 to 20 centimeters. When you're taking it superficial, one of the trick is actually you have to dissect it and bring it anterior to the sartorius. So that step, when you're actually turning it anterior to the sartorius, buys you almost 5 centimeters of extra vein. So yeah, and femoral vein is like 1 centimeter right from beginning. So it's amazing.
Himanshu, I want to ask you, in this particular case, whether surgical thrombectomy would work, like just going there, putting an incision, taking thrombus out, and do repair.
No. So what would have worked is actually you take slightly medial or lateral incision. Keep a good distance. Number one, these surgical thrombectomy patch, and I think probably one of the India's maximum. Patient's built-up is very important. So you don't do in a patient who has been marginally dialyzed and under dialyzed, bleeding, oozing, because these patients, when you create a long suture line, they will ooze to death. Okay, and they will end up with all kind of complication. If fairly patient has a neck pump cat is being dialyzed for a week or so, he's prepared, then you can go with a bit of medial or lateral incision. You should make sure that upstream vein is also good. You have to do an arteriotomy of entire length, thrombectomize the entire area, and then maybe just lateral vein you could have just used as a patch, or you could have simply used a bovine pericardium as a patch. Problem with bovine pericardium in patch in forearm I've seen, it still gives you, if patient is skinny, just like this patient, still gives you a wound complication. So maybe this was a much better option. Okay.
And is patch always needed, or you can just do a thrombectomy and resuture the thing?
Vein is
Because
actually
this is a
usually
dilated vein. This is a dilated vein. That's why I'm asking.
most of time this is area which it looks like dilated vein, but it's you have to resect a lot of vein. Okay, you cannot, so you have to actually go to the healthy area. Typically it becomes a thrombosed pseudorenal vein. So when you resect entire anterior wall, just the healthy posterior wall remains. That's one.
Thank you.
Yeah, thank you. The surgeon's perspective was even better. Now, I think we had a very long discussion over both the cases, and I thank our senior faculty are all been with us for a long time. I think we'll have to stop at some point, and we can have further discussion at a later time, 1-to-1 or so. Shall we close the meeting now? Yeah.
Thank you.
Yes, sir. Thank you, sir.
Yeah, thank you.
Thank you, everyone.
Right. Thank you.